Respected Chairperson, Sir, Professor Dr. R.C. Meena, Dr. Ram Prabhu, Dr. Prakash Segedar, and Dr. Sampath Dumbre Patil, it's an honor and pleasure to be speaking here to general orthopedic surgeons who probably see more of lumbosacral slip discs or PIDs than the standard spine surgeon. Is this an aging process or is it a pathology? This looks like a disc herniation at L4-5. This looks like a disc herniation at L4-5 and L5-S1. Both of them had black degenerated discs as well compared to the healthy grayish white disc above. And these are 3 discs which all seem to be degenerated and herniated or prolapsed, as we call in PID. 26-year-old gentleman only with this picture, weight trainer as a passion, marathon runner, back pain 3 years worsening, leg pain mainly on one side worsening for the past 1 year, says he gave up smoking at the age of 20, so imagine when he must have started it. He's complaining of paresthesia in the left L5-S1 dermatome, but is also having some weakness. And recently, about 2 weeks prior to my having counseled him, he's developed early sphincter urgency. Young man. Where do we go from here? Plain X-rays don't add much to what we've seen. Flexion extension confirmed that there is no real instability at any one of those 3 dark black discs. Sagittal MRI shows that all 3 are prolapsed if you look at it. Axial gives us some more information that L3-4 is more posterocentral, paracentral, going slightly to the left. 4-5 is surely a little bit more to the left, and 5-S1 is mainly to the left. We can do everything that you want, from CTs to everything that you want, but this gentleman has urinary symptoms now, which makes this a semi-emergency. So we have to go beyond controversies and come to a consensus that this gentleman, who I've been treating for a prolonged period of time, does he now move from non-surgical to surgical? And we all believe if this was our own son or younger brother, we would probably give them the option of surgery. The problem begins now. When you give them option of surgery, what do you counsel them for? And as I say, this is the most important part of treating a lumbosacral PID. Counseling, counseling, and counseling. What next? Why are we offering them the surgery is first to be spoken. Unfortunately, in our country, we begin the other way around. We begin with what? मैं आपका एक छोटा सा ऑपरेशन कर दूंगा. मेरे पास इतनी किस्म की machines हैं. So we talk of what and how. Rarely do we tell them why are we doing it. In this gentleman, it's the urinary sphincter insufficiency and the unrelenting left-sided pain which is not resolved. Let's believe that he is agreed for a surgery. Now as surgeons, do we do a discectomy with fenestration? Do we do a laminotomy? Do we do an interlaminar discectomy? Or we go back conventionally and do a full 3-level laminectomy? I want you to think, 26-year-old. We have new things in the market now called non-fusion options. These black discs, which may have been the cause of his 3-year back pain, may not necessarily be unstable. So could we give them a non-fusion, semi-solid option? Or do we have now takers for these disc replacements at 3 levels, or maybe interspinous spacers, which are soft stabilizers? Believe me, all these in 3 contiguous levels have not given the best of results. So we have to take a step back, learn, unlearn, and relearn. And we have to combine all that we know. If we were to fuse, would we fuse all the 3 levels? If we were to use what's called a hybrid, which is fuse 1 or 2 levels and keep 1 or 2 levels partially immobile, we could use this device which is called the isobar TTL, which allows physiological movement but does not allow pathological movement. That means little movement is allowed, but a slip is prevented. What did we finally do in this patient? We did a micro decompression at the highest level. At the next level, we did a decompression with a soft stabilization. And at the lowest level, which was that large 5S1 disc on the left side, I did a T-lift at that. This is what I had to combine. 7 years down the line, the young man still runs around, runs his marathon, and has been fortunate. This is an exception to the rule where we have combined all the three possible things that could be done. But is it that it should be done every time? No. Please follow the principle of miracle. Treat the man and not the scan. Keep repeating this. The MRI only adds to your clinical findings. Go through the ritual of examining that patient in detail every time. Follow minimal invasiveness, risks and costs having a lasting effect. How often do we get? Less than 45 is the commonest cause of disability. 80% of us get slip disc or lumbar disc herniation. Why does it happen? We all go through these phases, dysfunctional, unstable to restabilization and auto-stabilization. And the disc degenerates. It is universal. What causes it? Well, the annulus pops out. No, it's the nucleus which herniates through the annulus. What does it cause? It causes nerve pressure because that's a small pressure on that nerve root on one side. Let's look at this patient, 45-year-old, 4-day history, right more than left leg pain, L5. What should we do? Should we go in and remove that large fragment of disc that is asking to be removed? Well, I plead my case that I would not operate this patient immediately. And why do I say that? Well, any study that you go through, it says that the natural regression of the disc is extremely high. How high? 75 to 100% resorption in almost 50% of the patients. 50 to 75% in 12%, and less than 50%. Pathophysiology is not what makes the difference. It's the fact that the disc is larger, it has a higher chance of resorption than those young, small protrusions. The extrusions resolve much, much quicker. Do epidural injections give a better result? Short-term results, yes, but in the long term, conservative, with or without radicular pain, will settle. At the end of 10 years, there is no difference between surgical and conservative outcome. What happens as far as giving non-steroidal anti-inflammatories? No difference between pain and placebo, painkiller or placebo. Hence, what do? Do we use them? Yes, in acute scenarios, we can use them for a short period of time. Neurologically, minor non-disabling deficits will recover. Sensory fibers are the last to recover. Resolution with surgery, well, they do happen, but not always. And finally, to the last three prides. If there is a cross SLR present, you're asking for trouble. But if it's absent, it's a good result. If you get pain in the leg, even on extension, it's a bad result. Otherwise, it's a good result. If it's a large extrusion, it's a good result. If patients improve more than 50% in the first 6 weeks, it's a good result. Young, well-fit patients, it's a good result. Please remember, the motivated patient without psychological issues has good results. Poor outcomes, those who are unhappy, those who come with cauda equina, a positive cross SLR, a large lateral foraminal disc which is subligamentous, these have to be looked at. And finally, the last slide. What is it that does not make a difference? The degree of SLR. Don't keep measuring it. Response to bed rest. There is no place for bed rest more than 2 to 3 days. Passive physiotherapy, later. Women or men, they are all the same. And the degree of the deficit, except cauda equina, makes no difference. Thank you all for a very, very patient hearing.